We're talking about a door-to-door approach. This is regarding our study in Kerala. As you all know that glaucoma is one of the leading cause of blindness. More than 11 million people are blind in India. Early glaucoma detection is the only option because you know that it is irreversible blindness. But when you consider about the screening, it is different from cataract screening because cataract screening is easier to perform. You don't require much instrument for that. But glaucoma is difficult. It's time consuming. Even diagnosing glaucoma is difficult in field conditions. And mainly the hospital-based tests are required. So when you consider it, which are the tests we require for a diagnosis, definitely IOP recording is part and parcel of any glaucoma screening. Fundus evaluation, field test, gonioscopy and CCT. These are the minimum requirement for a glaucoma diagnosis. You know that these instruments are difficult to carry to the field and you require hospital-based screening for all this thing. When you consider this aspect, whether this is a cost-effective thing, that is a main question rises for glaucoma. So, how will you have an economic model? First, we have to decide who are the patients invited for the screening and how should all this group be identified, whether high risk or we are going to screen the whole population. Which of many candidates screening tests or combinations of tests should be used for the screening, open angle glaucoma or closed angle, whatever the study we are going to conduct it. Should a level of IOP as a considering factor, but you know that present stage we cannot consider a level of IOP as a screening process. Which place we have to screen, whether every patient we can complete it in the house is not possible. Should a screening positive test to be diagnosed as glaucoma? That is again is a problem with the glaucoma. The main problem, as I mentioned, is a low specificity and sensitivity of the screening test, and is time consuming. And most importantly, when we conduct it in a glaucoma screening, what do you understand in these situations is need patients' cooperation. I'll just mention about a few of the studies conducted in different parts of the India in previous years. Value study, we can see that 5,697 people were screened and 1,932 individuals of age group of 30 to 60. Here you can see that different studies will have a different age group targeted. One point you have to see in this study is they targeted on 30 to 60. So the eligible population, the percentage participated was only 50.3. This is one of the major points when you consider it in different studies. Whenever you select it in a younger population, you get a lower percentage of participation. Andhra Pradesh study, they targeted more than 40 years and they had a target group of around 3,724 subjects. Aravind study, 5,150 people were screened. Again is 40 plus year. Prevalence was 2.6%. Chennai glaucoma study is a good high number and high turnover. It is 80.2 on the urban side and 81.75 on a rural side, almost same on the response rate. West Bengal study, we will see that the highest percentage is from the West Bengal study, but you have to remember that here the people selected were above 50 years old. This is our study we conducted in Ernakulam district in Kerala. This was initially an ICMR sponsored multi-centric study. It was planned to conduct in Ernakulam, Delhi and Ahmedabad. We planned to have a 60,000 population. And our age group selected was 35 in between. So most of the studies are 40 plus, this was 35 years. And we calculated such a way that 1/3 of the population will be above the age of 35. So that we targeted a population of 20,000 people. So we divided into 6 groups, each group 10,000 each. And 3 rural area and 3 urban area we selected. First mapping was done by the field workers and household visit by the field workers. And eligible people, as I mentioned, it is 35 and above. People were asked to attend the local small camps actually we cannot call it as camp. Sometime it will be in one of the houses. And what we have seen, it should be less than 1 kilometer from their house. And vision and refraction was done for all the patients by qualified optometrists. No field workers or no one was asked to record the field. Proper refraction was done with the illuminated drums. All proper measures were taken to do the proper refraction. And all subjects were examined by the ophthalmologist, not by the optometrist. For the fundus was examined only with direct ophthalmoscope. Slit lamp examination was conducted on the selected patients who requires other tests, and IOP recorded for all patients with a Perkins tonometer, and that too by the ophthalmologist only. All disc suspects, IOP more than 21 millimeters of mercury, and angle closure suspects were called to the hospital for detailed examination. In hospital, all the patients underwent HFA 32 and repeated if the reliability indices were out of normal limits. And all the patients were underwent gonioscopy and detailed fundus examination at the hospital. Actually, the main problem was to increase the participation. So every area, at least 3 times camps were conducted. So one camp only, sometimes 30%, and again the same household, our field workers will be visiting again, taking it at least 3 times. Every area was screened, and local organizers were actually helping us to motivate the people. And lastly, the defaulters, few of the defaulters were examined at their residence if they were willing for the examination. Some of the people refused even that one. So finally we covered 13,622 household. Total population covered was 61,220, and total eligible people were 26,160. It was a little wrong from our initial calculation, because Kerala, the older population is more compared to the all India average. Total number of patients screened was 17,706, and this is the highest study ever conducted in Kerala, in India. Sorry, and we had a percentage of 67.68%. And when we were going to the defaulters problem, we found that males defaulters of 5,240, females was less. Actually, females were participating much more than the males. And when we compare the education level of the defaulters, illiterate actually 803, but very encouraging thing was newly literate. Those who are coming into the adult education program, they actively participated in this thing, and middle or secondary class educated people were the most resistant people. And the profile of defaulters, you can see that half of the defaulters belongs to the age group of 35 to 44. Suppose if you remove that, if you select it from 45 above, then your participation will be 83%. So that means that selecting criteria will have a very big influence on the participation of this thing. And older people participated much better than the younger patients. And most of the people said that we don't have time to come for all of the examinations. The funniest finding of this, actually half of the patients, half of the people who didn't participate in the study, they don't have any other job. They were jobless. And those who are having job actually participated much more than the jobless people. So this is, I will go through a few of the results of this thing as it is comparable to any other study in India. Prevalence of POAG on the age group, you will see that the prevalence increases from 35 to 44 age group to 65 to 74 having the highest thing, but when it is coming into the oldest age group, it again comes down. So it was 1.42 on the male and 1.22 on the females, that is a POAG. Then again the prevalence of angle closure glaucoma, again 0.36 on the male, and the females it is 0.46. And this is prevalence on again the same graph I am showing it. So this is a total prevalence is 2.2 on male, and females it is totally it is 2.03. Then the second this is showing about the suspects of glaucoma. Secondary glaucoma, again, it is comparable to any other study conducted. So I am not going to the details about the results of the study, but when you conduct it in a door-to-door approach, what we have seen that for this study which is conducted few years back, we have spent 10 million rupees. Suppose if you want to study a similar study now, it will be around 5-fold than this. So it's a very, very expensive study, but it requires to screen the people for glaucoma. So you have to find about some alternative methods, that is opportunity screening. Every patient coming to presbyopia correction, also in the same age group, so we can do it without much expense. Again, you have to increase the awareness of glaucoma, but the most striking feature is 80 to 90% of the patients who we detected as glaucoma had at least one ophthalmic examination on the previous 2 years, but it was not detected. So this is a most important thing. Thank you for your kind listening.
Thank you, Dr. Radha Ramanan.